Hello everyone and welcome back. Today, we're diving into one of the most important respiratory disorders you'll encounter in practice, pneumonia. Introduction. Pneumonia is an inflammation of the lung parenchyma caused by bacteria, viruses, fungi, or even aspiration of foreign substances. You may also hear the term pneumonitis used, which is a broader term referring to inflammation in the lung tissue that predisposes someone to infection. In the United States, pneumonia, along with influenza, remains one of the leading causes of infectious disease-related deaths. Together, they consistently rank among the top 10 causes of mortality. Classifications. We classify pneumonia based on where and how it was acquired. There are 4 major categories. 1. Community-acquired pneumonia, CAP, occurs in the community or within 48 hours of admission. 2. Healthcare-associated pneumonia, HCAP, found in patients who have had significant contact with the healthcare system, such as recent hospitalization, dialysis, wound care, or living in a long-term care facility. 3. Hospital-acquired pneumonia, 8B-CAP, develops 48 hours or more after admission, not incubating at the time of admission. 4. Ventilator-associated pneumonia, VAP, a subtype of HAP that develops 48 hours or more after intubation. Each category is important because it gives us clues about the likely pathogens and how aggressive we need to be with treatment. Community-acquired pneumonia, KIP. CAP is common, especially in older adults. The most frequent culprit is Streptococcus pneumonia, or pneumococcus. Other causes include Mycoplasma pneumonia, Haemophilus influenza, Chlamydophila pneumonia, Legionella, and respiratory viruses. Patients usually present with a recent respiratory infection, followed by cough, fever, chills, shortness of breath, and sometimes pleuritic chest pain. The onset can be abrupt with pneumococcus or more gradual with organisms like Mycoplasma. Healthcare-associated pneumonia. In HCAP, patients are at higher risk for multi-drug-resistant organisms. This includes people who've recently been hospitalized, live in a nursing home, receive home infusion therapy, or have frequent healthcare exposure. These cases are often trickier to treat, and initial antibiotics are usually broader until cultures guide therapy. Hospital-acquired pneumonia, HAP. HAP is one of the deadliest hospital-acquired infections, with mortality rates as high as 30%. Risk factors include prolonged hospitalization, mechanical devices like NG tubes, supine positioning, and immunosuppression. Common organisms include gram-negative bacteria like E. coli, Klebsiella, Pseudomonas, Acinetobacter, as well as Staphylococcus aureus, including MRSA. Patients often develop fever, purulent sputum, leukocytosis, and a new infiltrate on chest X-ray. Ventilator-associated pneumonia, VAP. VAP develops after 48 hours or more of mechanical ventilation. The risk increases with the duration of intubation. To prevent VAP, we use bundle interventions, elevating the head of the bed 30 to 45 degrees, daily sedation vacations and assessment for extubation, prophylaxis for ulcers and DVT, daily oral care with chlorhexidine. These steps, when combined, dramatically reduce VAP rates. Pathophysiology. Normally, the upper airway filters out pathogens, but when defenses are compromised, microorganisms can reach the lower lungs. Infection triggers inflammation, exudate formation, and alveolar collapse. This leads to impaired gas exchange, ventilation-perfusion mismatch, and ultimately hypoxemia. Pneumonia may present as lobar pneumonia, where an entire lobe is consolidated, or bronchopneumonia, with patchy infiltrates scattered throughout the lung. Risk factors. Key risk factors include chronic illness, COPD, heart failure, diabetes, AIDS, alcoholism, smoking and impaired airway clearance, prolonged immobility, advanced age, tube feedings or aspiration risk, immunosuppression. Understanding risk factors helps you target prevention and recognize vulnerable patients early. Clinical manifestations. The presentation can vary. Classic bacterial pneumonia, sudden chills, fever, pleuritic pain, tachypnea, productive cough with purulent or rusty sputum. Viral or atypical pneumonias, more gradual onset with headache, low-grade fever, myalgia, and non-productive cough. Severe cases may show cyanosis, orthopnea, and fatigue. On physical exam, you might find crackles, bronchial breath sounds, dull percussion, increased fremitus, and egophony. Diagnostics. Diagnosis involves history and physical, chest X-ray showing infiltrates, sputum and blood cultures, pulse oximetry or arterial blood gases. In severe cases, bronchoscopy may be used to obtain specimens. Management treatment depends on the type of pneumonia and the patient's risk factors. Bacterial pneumonia. Empiric antibiotics started quickly, then tailored based on culture results. Patients are often switched from IV to oral therapy once stable. Viral pneumonia. Antibiotics are ineffective unless there's a secondary bacterial infection. Supportive care is the mainstay. Hydration, antipyretics, oxygen, and sometimes antivirals such as oseltamivir for influenza or remdesivir for COVID-19. Supportive care for all patients includes rest, fluids, oxygen therapy as needed, and nutritional support. In older adults, pneumonia may present atypically, sometimes just with confusion, weakness, or anorexia, so maintain a high index of suspicion. Stash-Hanger complications. Complications can include septic shock, respiratory failure or ARDS, pleural effusion and empyema, delirium in older adults. These require rapid recognition and intervention to prevent poor outcomes. Nursing process assessment. Monitor for fever, chills, sputum changes, tachypnea, use of accessory muscles, and auscultatory changes. In older adults, look for confusion or behavioral changes. Diagnoses may include impaired airway clearance, activity intolerance, risk for fluid volume deficit, and knowledge deficit. Interventions focus on improving airway clearance with hydration, humidification, coughing, and chest physiotherapy, promoting rest and conserving energy, ensuring adequate fluid intake and nutrition, educating the patient and family about medications, preventive strategies, and follow-up care, monitoring and managing complications such as effusions, sepsis, and delirium. Evaluation. Successful outcomes include improved oxygenation, resolution of fever, effective coughing, adequate hydration and nutrition, increased knowledge, and absence of complications. Conclusion. To wrap up, pneumonia is common but can be deadly, especially in older adults or those with comorbidities. Early recognition, prompt treatment, and preventive measures such as vaccination and infection control are critical. Nurses play a central role in assessment, management, patient education, and complication monitoring.